So welcome to this webinar on cash and voucher assistance, CVA for health outcomes. It's organized with the Global Health Cluster, CaLP, CARE, IRC and KIT. And I'm Alice Gollet. I'm a Senior Technical Officer at CaLP, the Cash Learning Partnership. And it's my pleasure to be the moderator for this webinar today. So I will start by just giving a quick brief on the objective, the agenda, and the speakers today. So thank you. So maybe to clarify something, we had planned this webinar long before any signs of COVID-19. So the aim was really to enhance participants' understanding of the use of cash and voucher assistance for health outcomes based on research and projects to date. But we had to adapt the webinar in light of the current situation to make sure it would also provide some considerations in the use of cash and voucher assistance for health in epidemics. So we'll have 4 presentations today, and then time for question and answers. The first presentation will be an overview by Andre from the Global Health Cluster. Then we'll dive in the specifics of use of cash and vouchers for sexual and reproductive health in humanitarian emergencies with Fernando from KIT. Then we'll look into more details on household health needs spending and the burden of healthcare costs with Sana from IRC. And the last presentation will be on deciding how to use cash and voucher assistance for health outcomes with an example from Ecuador by Holly from CARE. So I will now introduce the speakers in more details. So we first have, it's a great panel, and we have the pleasure to have with us Andre Griekspoor, who's a Senior Health Policy Advisor at the World Health Organization, and he works for the Global Health Cluster. He's currently working in the Department for Health Emergency Interventions in the Fragile, Conflict-Affected and Vulnerable Settings Unit. He has worked for WHO for more than 20 years, and prior to that with Médecins Sans Frontières for almost 10 years in different positions and countries. Then we have Fernando Maldonado Costa, who's advisor at the Royal Tropical Institute in the Netherlands. He's a medical doctor and field epidemiologist with 18 years of professional experience, mostly in Latin America and sub-Saharan countries. Then we have Sana Khan, who's the Senior Research Advisor for the Economic Recovery and Development Technical Unit of IRC, the International Rescue Committee, where she spearheads research, learning, and global dissemination activities. And she has 10 years of experience in undertaking research and development in humanitarian contexts, working in these contexts and on many different contexts. And then we have Holly Welcome Radice, who is the Cash and Markets Technical Advisor at CARE, and who also co-leads the gender and the cash sub-work stream of the Grand Bargain. And she has over 20 years of experience in humanitarian and development contexts, with experience in Latin America, Africa, and the Middle East. So quite something that we have today. So on the next slide, we have just a few rules and information on the webinar. So this webinar will last 90 minutes. We ask you to please keep your microphones muted. We are many participants today, so we would really encourage the use of the chat for questions. We'll really be looking at the questions that are coming out through the chat, because otherwise it won't be so manageable. And we also wanted to inform you, yes, so please ask questions throughout the webinar in the chat. And then we just wanted to inform you that the webinar will be recorded and the recording will be shared. This way, also those who may not be able to join us today will have a chance to listen. And so without further ado, I would like to turn to André for the first presentation. And André, if you can remember to unmute yourself. Thank you.
Yeah, thanks for the reminder, Alice, and thanks for the introduction. Yeah, so and thanks everybody for joining. It's very nice to see such a large turn up and interest in the topic. So what I will do is I'll do an overview of where we were, some general reflection on learning on cash and voucher assistance in the health sector, as we started some 5 years ago. And because of the COVID epidemic and a lot of discussions that we saw on CaLP websites and from other partners, I added a few slides on how to interpret the general learning on cash and voucher assistance in the health sector, how to apply that in the epidemic. So if you go to the next slide. Now, one of the things that is sort of the foundational principle in the health sector is that there's consensus that when people are ill, they should not pay when they use a service, or said otherwise, that essential services in humanitarian crisis should be free at the point of delivery. And this means that we actually want to introduce measures that reduce reliance on user fees, as there's overwhelming evidence that when people have to pay for a service when they're ill, that inevitably leads to barriers for accessing health services, and also leads to what we call catastrophic expenditures, when people have to take loans or spend more than 20% of their household income on health services. Now, this is a position that does not only come from the humanitarian health sector. This is also consensus in the health development side. It's one of the foundations for health financing for universal health coverage. And you'll also see it in a paper that we developed a year ago with our health financing colleagues when we looked at financing in fragile settings. Now, this is all nice and well, but even though we all agree and all try to implement these policies, we do recognize and acknowledge that people, despite these policies, still have significant health expenditures, either directly for the services and medicines, or indirect expenditures for transport or cost for the caretaker. Next slide. Can you show the right side as well? I think I should have gotten rid of, oh, no, sorry, go back. So I think I deleted too much. When we started this discussion on cash and vouchers in the health sector some 5 years ago, when this became, the movement on cash became quite strong from following the World Humanitarian Summit, we first started looking at, okay, we do think that the health sector has some different characteristics from commodity markets, where people were of the policy that cash could, in principle, as a default, replace in-kind assistance. So some of the characteristics that we listed that need to be taken into account when you interpret cash and vouchers in the health sector is the concept of targeting. The becoming ill is not something that happens on average. It's a risk, and as such, the need to seek healthcare is not an average need. It's based on a risk and not on an average need. Then the thing is that when people are ill, the cost that they have for the treatment is not the same. It can be a one-off smaller payment, but it can also be a significant payment for admission. And it can be a cost that people incur for the rest of their lives if they have a chronic illness. Another thing is that we really want people to seek health services that are good quality. And also when they obtain medicines, that these medicines are of a guaranteed quality. So that means that even when people buy health services or buy medicines, we would really like to see that this is done from qualified providers. Another issue that we see is that often in humanitarian context, the supply of medicines is interrupted. and that both for the supplies, but also looking at quality of services, that these will always, to some extent, require some direct support to health providers. Then another element is that there's a whole series of preventive care in the health sector that does not always have the same demand as people have for commodities that they need on a daily basis, or for health, for curative care. And then a last component, and I'll come back to that later when I discuss a bit more on epidemics, there's a concept that we call common goods for health. And these are interventions that are mostly population-based: surveillance, risk reduction measures, factor control, water quality, but also epidemic preparedness and response that should be paid for by what we call public goods. That means that the government should finance these, and if households contributed to it, it should be through general taxation, and people should not pay for these kind of services. Next slide, please. Now this one I just show to make people aware of the broader health financing for UHC. So please don't look at all the details. I just want to walk you to two aspects of it. And that's in the middle, you see encircled by red, is that there are four core principles for health financing in general. One is revenue raising, and there's that means that revenues for health should be predominantly public. That means that the money should come from the government, complemented by donors. And if we get money from households, it should be through obligatory prepayment mechanism. And it's either your insurance premium or a different taxation mechanism. Then the other concept is pooling, so that we bring together funds for health. And then the concept of strategic purchasing for a benefit package. Now, the dominance in health financing for UHC has always been through supply side mechanisms, provider payment mechanisms, and our health financing colleagues for a long time had overlooked that this is good. By doing that, the unmet health needs will be reduced. But I think over the last years they started realizing that this is not enough, and that there's a whole set of demand side barriers that require additional interventions, including cash and voucher assistance. So if you show the next slide. So again, I will not go into the details of this slide. It's just one of the models that exist to analyze demand side barriers. And obviously one of them is cost, but there are also a set of other factors that may lead to delay in health seeking, or people not having access to services. But one of them is definitely the cost. And I think there's now a general more acknowledgement that in addition to all the investment that we need to do on the supply side and the supply side financing, that also demand side financing can have a role in reducing financial barriers and increase utilization of services. Next slide, please. I think I can. Can you do the next slide, or? No, okay, go back to the next. I think I overdid it when I took out the animation. So where we landed on all this thinking is that some 2 years ago we developed this working paper on cash and voucher assistance for the health sector in humanitarian settings, and there were kind of three key messages that came out of this work. One of them is that the first is that we indeed acknowledge that cash and voucher assistance can be useful to improve access to and utilization of health services by reducing direct and indirect financial barriers, or by incentivizing utilization of services that are for free. The next key message is that when there is if you wish, a health market, or meaning if health services are available and they're of adequate capacity and quality, but when people have to pay for these services, the preferred financing option is through provider payment mechanism, the supply side financing mechanism, with cash and voucher assistance to be considered complementary to those, and that we should not aim that demand-side financing should replace supply-side financing. So also this concept of purchasing services applies as the dominant mechanism. But when we do use cash and voucher assistance to purchase health services, that the best would be to target this to patients when they are in need of a priority service, and that the amount of the transfer should cover either the direct and or indirect or both cost for seeking that treatment, and that patients should only obtain those services from pre-selected providers that can meet minimum standards for effectiveness and quality. Next slide. Now, there's also a discussion on the role of multi-purpose cash and the link with its ability to assist in accessing health services or its contribution into health outcomes. So a long story short, but I think there's now a general acknowledgement that when people do get multi-purpose cash transfers for meeting basic needs, that this will also improve their ability to access health services. At the same time, we also do not wish that multi-purpose cash transfers are seen as a way as an entry point to finance access to services. And I go back to everything that I said earlier. Now, following this, there's a few key reasons why the health sector, cluster coordinators and partners should engage with multi-purpose cash assistance and the work that is being done by cash working groups on this in countries. One is indeed the acknowledgement that no matter what policy we have on trying to get services free at the point of delivery, that we always see in household surveys that households indicate that they use a proportion of their multi-purpose cash transfer for health. We see that these multi-purpose cash transfers do not have any effect on catastrophic expenditures. And if you understand the logic of illness and the diversity of expenditures, and you will understand this. The cash working groups do a whole range of surveys for basic needs assessment, and these surveys also look at health needs, they look at health seeking behavior, they look at barriers, and they look at health expenditures. So this is a wealth of information that the health sector can use to inform their programming. Another issue that keeps coming back in all countries when cash working groups and partners working on multi-purpose cash transfer start looking into this minimum expenditure basket, they will always come to the health sector and ask what proportion of the MEB should be for health, or how to integrate health in the MEB. So we do think it should be in there. We're working on some guidance for people to help explain how to do that. And the last issue why it's relevant to engage with them is that we can use the results from the post-distribution monitoring surveys. We can still see what the proportion is that people use for health, but also there's a component in there that is looking at negative coping mechanisms, asking people if they were not able to meet certain needs, what the reason was, or whether they had to have catastrophic expenditures linked to health services. And this gives us a feedback on our ability to ensure financial protection in the health sector. Next slide. So now, almost coming to the end, a few slides on looking at cash and voucher assistance within the current COVID-19 pandemic. So if you look at the left side, this, as I said earlier, anything that deals with surveillance, preparedness, and response to an epidemic, including the cost for treatment of patients, is considered a common good for health, and there should not be any charge to the patients. But also, as I stated earlier, when COVID-19 is being declared a national emergency, then government should consider to suspend user fees for essential health services from all providers for the duration of the crisis. Now, I think what what we then expect governments to do is that they find ways how to compensate. I think somebody needs to mute. Yeah, thanks. Is that governments need to find ways to compensate the loss of revenue and for providers to deal with increased expenditures. If they don't, you often see that that providers are simply not able to adhere to these principles, and that people still have to pay. Even sometimes we have examples that people had to pay for admission for I think it was Lassa fever in an African context. They got the medicines for free, but they still had to pay for admission and other costs. So they left the hospital still having to take loans sometimes. If this payment upfront is not possible, then the government should set up mechanisms for contracting or reimbursement mechanisms, or set up things that we call health emergency equity funds, or using voucher systems. But these usually take more time and are not always easy to set up quickly if nothing existed before. And then in addition, we think that if people then still have health expenditures for either direct or indirect costs, that we can look at targeted cash assistance. But again, it's not easy to set up all these systems within 2 or 3 weeks if nothing existed before. So we also acknowledge that obviously this epidemic does not only have a health impact, but also a very significant socio-economic impact because of all the preventive measures and the lockdown that many countries imposed. So many households lose their income. Also households, families that are quarantined or having to care for sick household members. And we do hope that governments will set up mechanisms for social protection. Many countries are doing one-off or longer-term cash transfers. And we do acknowledge that if the other measures that we think should be needed for people not to pay for health services, if these are delayed in their implementation, that these multi-purpose cash transfers will improve ability of people to access services. Next slide. Then there was a long discussion in the cash community on whether or not cash contributes to transmission, or how to interpret and apply different public health measures in the delivery of humanitarian goods and cash assistance. The basics are actually quite simple. So all vital sectors, and I think most humanitarian programming will fall under that, should basically or are expected to implement the basic preventive measures, physical distancing, hand hygiene, personal protective equipment for staff, IPC measures, disinfecting services that are regularly used by clients or beneficiaries, and implementing approaches in programming that allows people with COVID symptoms, or those that have to quarantine, to stay at home and have alternates collect the assistance on their behalf, so that you avoid people with symptoms coming to distribution sites, for example. So more specifically for the humanitarian assistance, if this is provided either through cash or vouchers or in kind, then organizations should ensure that beneficiaries can access these items safely and not putting either beneficiaries or staff at risk. Where it's possible, use mobile or electronic contactless payments, again, to reduce the risk of transmission, avoiding people to have contact with each other. There was a long discussion on whether ATM machines play a role in the transmission. Now, without going into all the details of how this epidemic transmits, the most important route of transmission is droplets that people spread when they have symptoms through coughing or sneezing to people who are close to them. So services can be contaminated, but I think their role in the overall dynamics of the transmission is moderate and small. And the basic measures to even reduce that risk is, again, by applying the same measures that I mentioned earlier, that the services should be disinfected regularly, and that when people stand in line for using an ATM machine, that they should keep 1.5 meter distance between the users. thinking a bit about vouchers or cash assistance in these public health measures, I could not come up with much except for that in many countries people already have troubles obtaining basic items like soap or other hygiene items or applying hygiene measures. So maybe there could be something on using vouchers for vulnerable households to access disinfectants and maybe soap. Next slide. I think this is the last one. There was a long discussion on what the evidence is for using cash and voucher assistance that we see in the development community and whether or not that could be extrapolated to humanitarian context. And I think some years ago, we sort of had some caution around that, and that we still promote to do further research and case studies for improved learning. But I think we more and more get to the point where I think we acknowledge that the evidence on cash and voucher assistance, or demand-side financing, as we call it, in development assistance, indicates quite strongly that it does add value, that it does help a very effective measure to improve access to services. And initial evidence on the use of cash and voucher assistance in the health sector in humanitarian settings indicates that we can implement those programs in humanitarian settings. And if we do that properly, then it has a similar effect as what we saw in development settings. So we do want to promote with a bit more confidence that cash and voucher assistance need to be consistently considered in all health strategies and humanitarian response plan. I think there's an increased need and demand from partners to develop more practical guidance, not should we do it, but when and how to do it. And for that, we need to collect more case studies and partners sharing their experiences. I think some more work can be done on how to manage risks that are more specific to humanitarian settings. I think any cash and voucher assistance has some risk associated with it, and maybe humanitarian context have some additional risk or exacerbate some of the existing risks. Last slide. Yeah, I think that was it. Thank you.
Thank you, Andre. That was a very strong message. Thank you. Consistently consider that. Yeah, and thank you very much for the great overview. So without further ado, Fernando, up to you, so that we can dive in the more specifics of cash and voucher used for sexual and reproductive health. Perfect. Up to you, Fernando, and don't forget to unmute.
Okay.
Hi, please look the question in the chat.
Oh, somebody's okay. Good afternoon, everybody. Also very happy to be here with you. I'll try to keep my time management. Let's see how it goes. Next one, please. Next slide. Okay. Ooh, the colors are different. Well, the objective of this presentation is to discuss the potential role of CVA during emergencies as a supplementary intervention, aimed at reducing barriers to access the utilization of SRH services. Given the current global situation, I'll try to make connections with the COVID-19 epidemic whenever it is possible. So we'll start with a very brief overview of SRHR rights during emergencies, looking at then potential role of cash and voucher assistance to reduce financial barriers, then look at the summary of evidence on the use of CVA for SRHR from both development and humanitarian settings, and finally we will discuss a few considerations that are relevant for this topic. Next one, please. Okay, so this presentation is largely based on a literature review prepared by KIT on the evidence and feasibility of cash and voucher assistance for SRHR services in humanitarian emergencies, and on the discussions that took place during a consultation meeting in Amsterdam early in March, just before the outbreak, while presenting the results of the literature review. Next, please. The first part of this presentation provides a brief overview of the SRHR needs during emergency. It will as well try to make a connection with specific needs and challenges for SRHR service provision related to the current COVID-19 epidemic. Next. Okay, aiming to put things into perspective, it's good to quickly revisit the definition of SRHR. There's a recently reviewed definition from 2018 that says that sexual and reproductive health is a state of physical, emotional, mental, social well-being in relation to all aspects of sexuality and reproduction, not merely the absence of disease, dysfunction, and infirmity. Which is very important from these new definitions, that in addition, it also emphasizes the right of individuals to make decisions about their bodies and access to services that support that right. So it is important to realize that then all people, including those in emergencies, do have the right to sexual and reproductive health. Therefore, in spite of the crisis and of any challenges that the health system may be facing, it is essential to respond to people's sexual and reproductive health needs. The definition covers aspects related to the sex life of people, to the wishes and decisions around reproduction, to the right to be informed and to have access to contraceptives, to having safe pregnancies and deliveries, to HIV and STI prevention and treatment, and finally to fertility regulation. This is very wide, very broad, and as you may know, for humanitarian situations, there's a revised version, which is the MISP. It is also interesting to realize that this definition provides a detailed description of the range of SRHR services that each person has the right to have access to. When you receive the presentation, in the link you will find the full definition, because I have chopped a few things to make it fit in the slide. Next one, please. Okay, so silly animation, I should have taken it off, but well, we are aware that in during emergencies, people may have amplified SRHR needs. They are, due to the circumstances, they may be struggling already to fulfill the basic sexual and reproductive health, needs. Next. So, and also depending on the circumstances, women and especially young people are also in need of protection services, following an increased risk of being victims of sexual and gender-based violence. Next. Now, these issues do not occur in the vacuum. A wide range of gendered implications result in additional challenges to allow women and girls to fulfill their SRH rights. Such gender implications can include, for example, women and girls often being put as caregivers within the households, which can have an effect on their physical and mental well-being, or reducing their chances of access and utilization of services. Also, during emergencies, livelihoods are impacted, and we know that often women are engaged in informal sector activities or low-wage activities that tend to be more affected. No need to say, in these circumstances, there are challenges in relation to hygiene and sanitary materials. Female-headed households tend to have more difficulties having adequate shelter, but also within the household, there might be issues related to the uneven distribution of resources and food sometimes. So this all creates a big challenge. Next, please. And one more, just to finish all the animations. Given the wide range of health issues included under sexual and reproductive health, it is important to realize that a multi-sectorial approach is needed while trying to ensure that SRHR rights of a population are fulfilled. Health services are just one of the elements of such comprehensive response. During emergencies, there are also multiple challenges for people to access services if they are available, and to ensure that those services are of good quality. Some things that you can imagine during an emergency, of course, services may not be available. There might be geographical access issues, financial issues, in spite of they supposed to be free at the point of care, and finally issues related to acceptability of the services. Next, please. Now, when we try to make a connection, a bridge with the COVID-19 situation, we can try to see the effects of the COVID-19 epidemic on two sides, the supply side and the demand side, left and right on this slide. On the supply side, and this refers to the processes and activities directly linked to the service provision, there's the possibility that human and material resources will be diverted to respond to the outbreak. This was mentioned by Andra already. Some services may not be fully available. Another potential effect is in relation to the diversion of financial resources at the international or national level. COVID-19 can be used as an excuse to drop some components of the SRHR response, the minimum response, based on the argument that they are not essential. In certain cases, maybe you're aware of situations like, for example, safe abortion that has been dropped. Finally, and at the global scale, it is important to realize that this COVID-19 crisis also brings challenges in the supply chains, leading to shortage of drugs and medical products, things that we see already with factories in China or in India being closed. When looking at the potential effects on the demand side, now we're looking at the right side, and this refers to processes to decide, seek, reach, and use services. It is possible that the outbreak will increase barriers to seek for care. This possibly due to competing household activities. As explained in the previous slide, women and girls may be more affected given the role of caregivers that usually assigned to them. In addition, control measures for COVID-19 can include restrictions in mobility and/or suspension of public transport. This will reduce the capacity of people to reach the needed services. Possibly, the effect will be larger in population subgroups from lower socioeconomic status, as you can imagine. In addition, people may fear getting infected as a result, and as a result, opt to remain at home. Finally, this is important to keep in mind. The disruption related to the outbreak will result in a reduced household income. This will for sure affect the capacity of households to pay for direct or indirect costs related to service utilization. In addition, the reduction on income may also affect service providers. As such, they can be encouraged to start charging fees legally or under the table, which will affect as well the financial access of the population to these services. So there are multiple ways through which this COVID-19 epidemic can affect SRHR utilization. Next, please. When we look at the role of cash and voucher assistance to reduce financial barriers to SRHR services, next. I think most of you are familiar with CVA, but in case somebody is not fully aware, cash and voucher schemes and programs can take multiple forms and shapes in relation to the objectives of the intervention. They can be, for example, assistance to cover basic needs versus sector-specific ones. There can be difference in relation to the modality, cash or voucher, obviously, in the way of delivery, electronic or physically, and finally to the conditions to receive the assistance or to any restrictions or not to use it. In spite of the multiple forms that CVA can take, it is important to recall that the effect of the voucher schemes and cash transfers mostly affect users of the health system, and therefore they are called demand-side interventions. Next one, please. Okay, if we try to see, we go back to the slide that we showed a few minutes ago. Now there's a red, no, sorry, I was just referring to that. Please remain, yeah. In this slide, now we see a red circle appearing, and basically that's where cash and voucher assistance will have the major impact, let's say, or where they can be more useful when we see where the COVID-19 situation affects SRHR services in humanitarian or emergencies. As mentioned before, CVA is more evident or more important on barriers located on the demand side. So we'll be looking at interventions that increase, that will help to reduce barriers to reach or to pay for for services. Next, please. Aiming to have a more detailed view of where the CVA can play a role, we can use this conceptual framework that was developed by Levesque to analyze access to healthcare. Next one. And when we zoom into it, yes, we can see that the factors on the supply and on the demand side are described. Supply on the top, demand on the lower side. And within the demand side, we can see where exactly cash and voucher systems can play a role. In my original presentation, it was red, but now you can see some boxes in blue: ability to reach and ability to pay. Those are the places where cash and voucher systems will directly have an effect. And in a more indirect way, it is expected that it can have effects on ability to perceive, to seek, or to engage, be it by providing, for example, more autonomy within the household, or by empowering women to seek for services. Next one, please. A couple slides about what do we know, what is the evidence around the use of CVA for SRHR services in development and humanitarian settings. First slide, next one. So disclaimer, this slide is borrowed. So this information was presented by Anna Horter. Is one of the experts in the field in a meeting in Amsterdam recently. And I have taken the liberty to take some of her key messages. But what is very, very important to realize is that on the demand side, there's robust evidence that vouchers do increase service utilization at different types of services. It is also important to realize that while cash and voucher assistance can reduce financial barriers, there are many other types of barriers: cultural, social, geographic, health systems factors that also play a role, and as such need to be taken into consideration. Just by providing cash or vouchers, the situation will not improve automatically. At the bottom of the demand side, you can also see that there's emergent evidence that vouchers are cost effective and that can change health seeking behavior in a sustainable manner. And this means that once people have learned or experienced a certain behavior, and this means maybe using services, even if the intervention stops, some of these behaviors will continue. When we look at the effects on the supply side, it is important to highlight that CVA, on its own, can't solve issues related to access and utilization of services. Supply side interventions are always needed, and it is important to keep in mind that the increased demand for services resulting from using cash or voucher assistance will put extra pressure on the health system. Next one, please. When we look at the evidence from humanitarian settings, well, this is basically the work that we did at KIT in the past months. We came up that we only found 28 published documents. It was for us a limited amount of evidence. Half of these documents were from humanitarian settings and half from fragile settings. As such, we are aware that the evidence is not yet abundant, but the body is growing all the time. The literature review is very much consistent with what is described in development settings. Increase of service utilization, and also that there's a lot of experience concentrated on programs focusing on safe motherhood, family planning, and gender-based violence. There is little evidence, published at least, about the use of cash and voucher assistance as complementary intervention for other components, for example, post-abortion care, HIV, STIs, or adolescent SRHR. From the supply side, it is important to highlight that especially vouchers were linked to motivation of providers to keep offering services that kept running in spite of conflict, that they saw client bases expanding. So even if the main focus of cash and voucher assistance is on the demand side, some positive effects were observed on the supply side as well. Next one, please. So 2 slides with considerations. I'm sorry, I'm already over the time. It is important. There is evidence from developmental humanitarian settings showing that CVA can increase utilization of services. This is positive for sure, but higher demand can increase pressure on service providers. As such, it is essential to combine CVA with supply-side interventions, health system strengthening, for example, and to ensure that links with services in other sectors are made and are functional. This will help to reduce barriers at health systems level and will increase chances that services are delivered with sufficient quality. It is also clear that barriers to access SRHR services are not only financial ones. Social, cultural, geographic, and health system factors can also block people from using services. It is therefore important to have a comprehensive approach. Evidence suggests that CVA in emergencies is mostly used in projects focusing on safe motherhood, family planning, GBV. There is less information about the experiences of using CVA for projects focusing on safe abortion, adolescent SRH, or while addressing SRH needs of vulnerable or diverse, gender diverse groups. While this finding can reflect the type of SRHR programs that are implemented in humanitarian settings, it is also possible that CVA may not be easy to apply for all SRH components. For example, it can be controversial to include cash assistance in a program focusing on adolescent SRH. Evidence and effects of CVA focus almost exclusively on indicators of service utilization. While this is useful to measure the effect of CVA on service utilization, the current evidence does not provide sufficient detail about how CVA actually helps to reduce barriers and improve access and utilization. It seems essential to include more information on reports coming from post-distribution monitoring as well as qualitative information collected from recipients. Next slide, and then I finish. Given the burden of COVID-19 epidemic on health systems, efforts need to be done to secure additional resources to ensure continuity of provision of essential health services, including SRHR services. Both COVID-19 services as well as SRHR services are considered essential. Being a demand-side intervention, CVA does have a limited effect. I want to make a correction from the slide that says does not have an effect. It says a limited effect on supply-side issues or problems. Specific actions need to be in place aimed at strengthening the health system. Finally, it's important to be aware that in principle, health services provided in humanitarian contexts are free at the point of care. In spite of this, it is often the case that people actually incur on indirect or direct costs to be able to use services. Depending on the modality of CVA chosen, this type of assistance can have a role in reducing financial burden within households and in reducing financial barriers to access health services. This can potentially lead to improved seeking behavior, improve accessibility, and improve affordability of SRH services. And that's it. Sorry for going over time.
That's fine. Thank you so much, Fernando. Thank you, and very important considerations. Where you have time, we turn right away to Sana for the third presentation on how households face costs related to access and burden related to healthcare needs. Sana, up to you, and please unmute your mic.
Great, thanks, Alice. Hi, everyone. I'm Sana Khan. I'm with the International Rescue Committee on the research team. Am I unmuted now? Yeah. I'll be talking today about a particular research study that the IRC did. And just as a little bit of a background, in 2017, the IRC was interested in understanding whether and how cash assistance could be used to meet first order health outcomes, like more timely access or increased utilization of health services. But there was very little practitioner guidance or evidence from humanitarian settings on how to approach this programming. And as Andre mentioned, we know from post-distribution monitoring surveys that households spend on health, but we know that at a very higher category level, like we don't actually know more details than, yes, households are spending on health. So overall, we had very little understanding of how are households prioritizing health needs, whether they're seeking services. If they're seeking services, what are the expenses that they're incurring? How do they meet these expenses? And what is the role of cash assistance in all of this? Next slide, please. So we decided to do some research that would help us understand this a little bit better. It had 3 primary objectives. We wanted to understand household level prioritization of needs. We wanted to understand what expenses they were incurring. Just a heads up, Lynn, Alice, it keeps telling me that I'm getting muted by the host. Anyway, I trust you can hear me now. Great, thank you. So what expenses households are incurring and how they're currently being met. And through all of that, what we wanted to arrive at was to see if there is a role for cash assistance in all of this. So before I get started, just sort of one quick note that, overall, this was a descriptive study. We were trying to document prioritization, expenses, and how these expenses are being met. The intention was not to understand the impact of cash on health outcomes, not even first order health outcomes, but just to sort of map what was happening in households. Next slide, please. So we did the study in 3 locations in 2 countries, in Pakistan and in Cameroon. And the way that we set it up is we decided to build on upcoming cash programs and set up the data collection such that we would get a before, during, and after picture on health spending and what happens when there's an injection of cash in the household. In the 2 contexts, the cash programs looked a little bit different or a lot different. But they were, the important thing is that, they were both programs which were cash for basic needs. There was no explicit health objective there. And they're both unrestricted. So people can spend the money however they deem is important for them. So I guess the two main things to get out of that is, they look like typical cash assist or humanitarian cash assistance programs, and people can choose to spend them however they want. The selection criteria was slightly different. The transfer amount was based on minimum expenditure baskets, and through community, the targeting was done through community consultation. So those details look different, but in terms of objectives, it was the same. Next slide, please. So in terms of the research design, we used 3 research instruments. We had a quantitative tool, a qualitative tool to supplement it, and then we also did a rapid health facility assessment in the area of the intervention. The quantitative tool, which was the most elaborate, was high frequency data collection. Like, we collected data every 2 weeks to understand like what was happening in the household in terms of spending, spending, particularly health spending. And then we supplemented that data by qualitative semi-structured interviews at sort of very specific points in time where we wanted to understand something better. The supply side, it wasn't comprehensive in that it didn't capture everything, but what we wanted to get a sense of was whether there were services available in our intervention areas. In all 3 settings, and we captured both. I'll go into a little bit more detail on this, but we captured both public and private facilities, and then also documented the presence of informal health services. Can we go to the next slide, please? So starting off, our intention was to do a data collection over a 6-month period. Obviously, that didn't quite go as planned. So we had 11 rounds of data collection in Pakistan, and we had 9 rounds in Cameroon. And those that difference really comes from the ground reality and the situation we were dealing with in the two contexts. And then in Peshawar and Bannu in Pakistan, we had roughly 100 people that we were following, and in Cameroon it was slightly higher. So in Logoneshari it was 128 households. Just one note before I start talking about the data is that, you know, just from these numbers, you might realize that our sample size was quite small, and so particularly for certain kinds of health needs or health-seeking behavior, the sample size shrinks even more. And so, given that a small sample size is prone to outliers, we mostly present median values in this presentation and in the report that accompanies it, as they tend to be more stable and more robust against extreme values. Next slide, please. Actually, can we skip to the next one as well? Thanks. So just a quick note on the economic profile of the households that we were following. So the most important thing to note here is that we're talking about extremely vulnerable, internally displaced persons and also host community populations. The median household income across the board is below the minimum wage. It's often below the poverty line. And the cash transfer was a very significant % of the income, which is also interesting because like people who are familiar with the minimum expenditure basket also know that it's meant to capture like households' basic needs. So here what we're essentially saying is that actually their income, they're so vulnerable that their income is not even meeting their basic needs. Can you go to the next slide, please? So, you know, just not specific to health, but just some sort of quick notes on the economic piece. Still, you know, as expected, we see that cash increases purchasing power. So we find that spending on most things increases, but primarily that's primarily driven by food. We also see that people are repaying loans, and that fewer households are, or borrowing decreases in households. Next slide, please. And one more. Okay. So as I was mentioning earlier, we did, our supply side was a rapid supply side assessment. We did data collection at different types of facilities, and then we also used IRC field offices to gather additional information on NGOs that might have been providing services in the area that are not necessarily captured by our health facility assessment. We captured information on basic drugs and supplies, on services available, on equipment that was functioning in these places, and then also to some extent on access. So we try to document like fees, registration fees, consultation fees, things of that nature. We didn't capture informal fees as a part of this. And then overall, we tried to get at least 2 types of facilities in the intervention area that we were, that the cash programming was happening in. So as long as there were two facilities, we tried to capture information on them. If there were more than 2, then we just selected 2 out of them. Can we go to the next slide, please? Thank you. So overall, what we found is that in all 3 locations, we have some supply side, like it's not, it's different for the different types of facilities. We see that, but we see that some supply side exists in all 3 locations, both in terms of services and equipment, but also in terms of drugs and supplies. But it's uneven across the 3 locations. So we see that Peshawar has the best supply, which is maybe also not so surprising because it's an urban area. and we see that the other two have a slightly worse supply. We also see that the supply of drugs and supplies is better than basic equipment. And next slide, please. And we also see that in both locations, there are some organizations or sometimes the government providing free services. So for example, and we could see this very clearly in our data as well, in Cameroon, the government provides vaccination services free of charge, and like there's sort of National Immunization Day or Vaccination Day, and we see spikes in usage during those periods, and we don't see an accompanying cost. So there were some services that were being provided free of cost from the government. And then there were, in addition to that, there were NGOs that were providing free services for specific populations. Next slide, please. And one more. Great. So our quantitative data collection captured a lot of detailed information on preventive healthcare, unpredictable health needs, predictable health needs, etc. But today I'm only going to present an aggregate picture to convey sort of household burden of health expenditure. But we have the report for this research published and have a lot more details on spending on preventive needs or specific types of other health needs. So, you know, and the report also includes a lot of detailed tables on spending and across rounds of data collection. So I encourage you to take a look at that if you're interested in the details. Next slide, please. So in general, what we observe is that in any given round of data collection, which means in any 2-week period, at least 30% of households, and often more than that, households are reporting having health needs. We also see that people mostly seek care when they have a need and mostly incur a cost for doing so. This varies by geographical location. So for example, in Banu, we saw that people were not always seeking care, and there were a range of reasons for this, including like the illness not being considered serious enough, or high cost of care, or facilities being too far away. So there is geographical variation, but overall we see that, you know, at least 30% of the people in any given round are saying that, you know, they have a health need, they're seeking care for it, and they're incurring a cost. Yeah, this need and subsequent action and cost is important because it suggests that services are not necessarily free at the point of delivery, or even if they are technically free, there are other costs that these households are incurring. Next slide, please. So on the low end, we see that the cost that people are incurring across the 3 sites, on the low end, it's about 35% of their reported income, and at least 10% of the transfer amount. So, I mean, those are numbers from 2 different sites. So you can see the details on the slide here. But just to say that it's a high percent, like in Logoneshwari, it's more than 100% of reported income, and at least 10% of the cash transfer amount. Next slide, please. And then in terms of catastrophic expenses, and sorry, just to flag that Andre gave a definition for this earlier in his presentation, and we used a slightly different definition, so don't get confused by the 20 versus 40%. But what we saw that, you know, not in every round of data collection, households are not experiencing, or like a lot of households are not experiencing catastrophic expenditure, and that's to be expected. Like, we don't think that, you know, every week a household has a major health crisis. But we see that some percent of households report experiencing catastrophic expenditures in every single round. And we see that this can be as high as 45% of households in one of our settings in Peshawar. And this, I mean, I guess relating it to the current situation, we see that this is even more relevant now given COVID-19, because from an economic lens, we know that people are either going to lose their income for the foreseeable future, or we know that they'll expose themselves to greater risk if they try to pursue economic activities, because it may not be feasible for them to social distance in that case. And from this data here, we know that even in the absence of a pandemic, households are seeking care and incurring a cost. So for these households with income decreasing and potentially health expenditure increasing, the likelihood of catastrophic expenditure also increases. Next slide, please. And so in all three settings, and these are the slides for Pakistan, and we'll see Cameroon on the next one. In all three settings, we see that once there is an injection of cash in the household, the use of cash to meet health expenses increases once the cash assistance starts, and the use of loans to make health payments or to make payments for health services decreases. Next slide, please. So this is the one for Cameroon. And so from a combination of our quantitative and our qualitative data, we see sort of two ways in which people are using their cash transfer for health needs or purposes. We know that households are using cash assistance to make direct and indirect payments for health needs. And we also know that they are using the cash assistance to pay off loans that they may have previously taken out for health needs. Next slide, please, and we might have to skip two. Yeah, one more. Okay. No, back. Yes, thank you. So in terms of sort of the main conclusions, and these are again focusing more on sort of the aggregate information that I was sharing. The report has more details, but acknowledging that we didn't do a full mapping of all the health services available, we find that households are still spending on health needs, and this cost is driven by direct expenditure. There is some indirect expenditure, and that's largely driven by transport costs. So free services at the point of delivery doesn't hold true in these settings. But even if it did, there are other costs incurred before they get to the point of delivery. And so people are using cash for that. We also see some suggestive evidence. And again, our sample size is small here, so just keep that in mind. But we see that cash may be facilitating timely access or influencing care-seeking behavior. So in Peshawar, we saw that there were peaks in delayed care when there was a gap between the first transfer and the second transfer. So that wasn't by design, it was because of implementation challenges on the ground, but we saw that there was a peak in delayed care in the interim. In Cameroon, we also saw that there was a decrease in those not seeking care once the cash assistance kicked in. Next slide. And so just finally, and this is very consistent with a lot of what Andre was saying in the beginning as well, our first recommendation is really related to ensuring that services are actually free at the point of delivery. Similar to the GHC and WHO, the IRC, for example, supports the principle that healthcare services during humanitarian crises, such as an infectious disease outbreak, should be offered free of charge. And humanitarian actors should coordinate to ensure that this is the case. But even then, we know that individuals might incur direct or indirect costs related to health. So our second recommendation is that, when health is identified as a priority need, it should be included as one of the ingredients in the minimum expenditure basket. And, it might be hard to account for this on a case-by-case basis, as Andre was pointing out, maybe we can't talk of this in terms of an average risk. But with the COVID-19 situation is a good example of an external shock that's applying to everyone. And on the economic side, cash assistance could work to serve it could serve to protect assets. But on the health side, it could be used to meet emerging health needs without households resorting to negative coping mechanisms. Next slide, please. And then finally, we just recommend taking extra measures or considering additional support. And this could be cash or it could be other options to support specific subpopulations, such as pregnant women, to ensure that services are genuinely free and that they're able to access services and don't incur a financial cost to do so. And so I didn't go a lot into the details of sort of pregnancy-related costs, but we see that, you know, in our settings, these services are available for free, but we also see women reporting incurring costs to access these services. So I'll stop there. That's all I have. Passing it back to you, Alice.
Thank you so much, Sana, for this great presentation. Really interesting to see that, yes, households do incur costs related to healthcare anyway, and that also cash can have a positive outcome on their access to health and reducing those financial barriers. So thank you so much. And last presentation now with Holly, who will take us in Ecuador. Holly, yes, I turn to you, and yeah, you're already unmuted. Thank you.
Thank you so much. And thank you all who are still here. It's my pleasure to be presenting on behalf of the team in Ecuador. And just to say with a caveat that this is presenting pre-COVID, as the situation has changed quite dramatically in Ecuador at this point. Next slide, please. Before I start, I want to mention that this project is funded by the U.S. Bureau of Population, Refugees, and Migration, the Department of State, and in concert with our partners, Alas de Colabrí y Diálogos Diversos. Next slide, please. A little bit about the context in Ecuador. So the humanitarian crisis in Venezuela is affecting 16 countries in Latin America and the Caribbean, including Ecuador. Almost 5 million Venezuelans have fled their country, and that's about 500,000 that are in Ecuador. In response to this crisis, cash and voucher assistance has been used by a variety of actors in Ecuador, mostly under the guise of multi-purpose cash transfers, but also there have been cash transfers and vouchers for sectoral outcomes such as shelter or for WASH. In Ecuador, healthcare is universal and it's free, irrespective of your nationality or your status. And the government, it's generally pretty good, but the government has made efforts to increase in the response, but one can say that it's saturated because of the demand, and this is especially in the areas where migrants are congregating. Migrants are arriving in poor states. Many have chronic health issues because of lack of attention from the collapse of the services in Venezuela, and that's really worsened by acute health needs because of their journey. In terms of Care Ecuador, we in country have been implementing an integrated response, which leads with a protection lens, and we're working in the sectors of protection, shelter, WASH, basic needs through multi-purpose cash, and we've also used voucher assistance since 2018. We've seen a real change over those few years, and so we've been trying to see how can we move ahead to shift to the more pressing needs where there are gaps. Next slide, please. So in pursuit of that, in November of last year, CARE and our partners, we completed a rapid gender analysis to identify humanitarian needs and gaps concerning rights, sexual reproductive health, WASH, and shelter, and make recommendations on those. And so this has really guided the way of thinking, and some highlights related to health are that 57% of the migrants that we spoke to claimed that they had no help, that they needed health attention, but 84% had not received it. There were considerable differences in that response for women and members of the LGBTQI+ community, and they more frequently mentioned that they needed access to those services. There was high knowledge of anti-contraceptive measures across all groups, except with adolescents. Even though we had a rather high understanding of anti-contraceptives with adults, women and men said that they had no access to these measures, and or they had very low access to it, I should say, and it was and LGBTQI population said that they were much less likely to have access to these measures. So looking at some of the reasons why, what were the barriers, and these have been mentioned in Fernando's and in Andre's presentations already, but bringing it to the Ecuador context is that They related to lack of information in terms of the Ecuadorian health system by Venezuelan migrants, xenophobic behavior on part of some of the service providers, and some traditional stereotypes that really made barriers into seeing who would go ahead and look for certain types of services. And lastly, we spoke to health professionals who also pointed to congested health centers, and also that they noted there was an increase in risky pregnancies and births, such as teenage mothers and mothers with STIs. Next slide, please. A little bit about the project concept. So as I said, we are leading with a protection focus, and this is especially focusing on women and LGBTQI populations and looking at sexual reproductive health. For this health component, we have targeted Venezuelan migrants and a smaller percentage of vulnerable Ecuadorians. I'm not sure if the points are not coming up, Lynn, but you can feel free to go ahead. We've sought to meet the health needs based on the Ministry of Public Health directives, the National Health System, and also the minimum initial service package for MIS.
I found a catty.
Somebody has found a party. That's great. As these needs depend on the participants, we've analyzed local markets for goods and services. So we've done what is, basically a market assessment using the lens of cost efficiency, of needs, and also the ministry standards. And we've looked at both public and private sector providers to be part of this scheme. Next slide, please. So here you can have a sense of the 6 different types of vouchers for health that our teams have come up with. You can see the broad categories. Who receives what and what, as in sense of what type of voucher, depends on their need and the type of participant. So CARE with our partners, we've developed SOPs, standard operating procedures, to work through the processes from identification to monitoring, which take into consideration the privacy of these highly vulnerable populations. And so the SOPs make clear to what the voucher is supposed to cover and the intended groups. I don't have time to go into that now, but I'll give you one example. Each voucher has a maximum value which is connected to it based on the costs of the goods or services. Again, reflective of that market survey that I talked about. And also looking at the suggested pharmaceuticals from the Ministry of Health. And so, for example, the first voucher that you see there for medicines and specialized examinations, a woman who is a GBV survivor could access up to $150 US, while an LGBTQI person would be able to access up to $30. Just to point out that Ecuador is a dollarized economy, if you're not aware. So participants can access, again, on the particular areas we're working, either public or private, depending on the location and the capacity. It's important to point out that we pair the vouchers with complementary services and distributions. And so these have included workshops on sexual reproductive health, GBV prevention, sexual diversity, and human trafficking. Next slide, please. So here you can just get a quick look at the vouchers our participants receive. The one on the left is for lab tests, and the one on the right is for necessary prescription drugs. Next slide, please. So looking at the results and the next steps, overall our partners, so CARE and our partners have provided medical support to more than 3,000 people. You can move with the bullets, please. And that includes nearly 600 people receiving vouchers for medicines, treatments, medical tests, STD and HVI screening, pregnancy tests, contraceptives, and lubricants. Just over 500 have received medical attention and referrals to the National Health System, and over 2,000 people have been assisted through sexual reproductive health or emotional health sessions. So CARE with its partners has achieved good coordination with the Ministry of Health at local levels, which is essential to address these urgent needs, and we're really proud of that. And looking ahead for CARE Ecuador, we're looking to extend and improve upon this voucher scheme to integrate it with ongoing cash in voucher assistance, which being used in our GBV case management programs. We're really putting considerable focus on learning from this experience to improve as we go, not only in Ecuador, but also throughout the region. And lastly, I can say at a global level, CARE has taken a priority to increase how we are doing cash and voucher assistance for health outcomes. And so from this experience, we're going to be sharing again within the region and also globally. And that is it. Thank you so much. Back to you.
Sorry. Thank you so much, Holly, for this. So yes, so we're running now into the question and answer session with 4 minutes left. So I think it's safe to say that if okay with you, we will just we will keep 10 more minutes from now, and that's it. There have been so many questions in the chat box. There's been an army of responders. I think most of them have been answered. So I will just ask to our speakers three questions together, and we'll see who may want to reply, because I think many of you could answers to the various ones. There are also some of the concerns we had received through the questions through those who had signed up. So I will ask, first question is, how would you evaluate the level of expenditure in health, considering the unpredictability of healthcare needs? So for example, when you try to set a transfer value, so that's a bit general. If any of you have reflections on this. How do you ensure the quality of healthcare when delivering cash and voucher assistance? So how do you ensure that the quality dimension is really included? And here, the participants were also wondering of the quality when it comes to the purchase of medicines and some of the limitations donors have put on purchase of medicine locally, for example. And the third one would be on how to address adolescent health outcomes. Also, when you have unaccompanied children or children-headed households, when you use cash and voucher assistance. So is there a good way to go about this? So I leave the floor open to you, Andre, Sana, Holly, Fernando, if any of you have anything to say about these three questions, please.
Hi, Alice. Oh, go ahead, Andre.
No, you go first. I'll come later. Thanks.
I was just going to say one thing that, and actually, I mean, Andre might be better placed to answer this, but one point that I just want to highlight from IRC study, but also that was flagged earlier, is that you know, and this is, I think, in reference to the second question, the idea is not for cash assistance to replace the supply side. Cash assistance very much in addition to strengthening the supply side and making sure that that is available and of high quality. And then this is just the cash assistance is only intended to sort of facilitate access or reduce the financial barriers that people might have. I'll pass it to Andre. I'm sure he has more to say on that.
No, I have something complementary. I think of all the cash and voucher options that exist, I think vouchers have the best characteristics to deal with those questions on different costs linked to different health services and different medicines, and also the issue of quality, because a voucher, just like forms of contracting, require agreements with pre-selected suppliers or health service providers. So you can make agreements on the price of different services, and you can set some standards with these providers to see if they comply with a set of quality standards, and that the medicines that they provide adhere to some regulatory standards. So we had some partners that piloted value vouchers, where they gave at a potential of an average value to different targeted households, and they quickly found that obviously people with chronic health needs use the voucher much faster than young families in relatively good health. So I think they switched to a service type of voucher where people had the potential to benefit from a service, and then the NGO reimbursed the provider of the real cost linked to that particular episode of illness and the treatment that was needed. So vouchers, they have the best characteristics, and if you give cash, I think some partners did what, how did they call it? It's sort of a pre-commitment. For example, cash given for pregnant women in the 32nd week of pregnancy. They had discussions with these women during antenatal care and had discussions with them to give them advice on which facilities they knew were able to adhere to good quality standards, so that the quality of the delivery, and if these women needed C-sections, that the quality of the surgical care adhere to certain standards. But then you have no control that these women will actually go there. But yeah, it did show that when you have these pre-commitments from women in advance, that they do tend to go to these facilities that provide quality care. Over.
Okay, thank you, Andre. Thank you, Sana. And I saw also that, Holly, you responded to the question that was directly addressed to you in the chat box. I don't know if you've just put on your camera to answer.
Yeah, no,
yes.
I also, just to try to answer a question there, I think that, I mean, what we had done in Ecuador was intentionally vouchers because of the mobility of these populations. And so it's a little bit difficult for me to answer the question related to expenditures, but I would just really want to add that in this case, where we're talking about people that are migrating from different places, and Ecuador has been a place of transit as well as a place, a destination, is we really want to reinforce the accompaniment that needs to be involved with that. And so we felt that vouchers were not only going to give the best quality of care, because we were able to look at the different facilities where they could potentially be going, but also that we would ensure that they actually were seeking the services while they were deciding on their migratory route. I hope that's helpful.
Definitely. I think that maybe, given the time, we just go to the conclusion slide. And thank you all for those really interesting questions. We just wanted to share a few key resources. The purpose of this webinar was really to give you keys to how to consider the use of cash and voucher assistance in health, and I hope that we were successful in this. I would like to reiterate a huge thanks to our 4 amazing panelists today. So thank you so much for all of your presentations. And thank you also to Lynn, our colleagues Lynn and Yasmin, who worked behind the scene to make this webinar quite smooth. You have our contacts in case you want to follow up on anything bilaterally, and we said that we would share this, the recording of this webinar and all the information that goes with it, hopefully tomorrow. And I think we all together, thanks so much, all of you, for joining and for staying until the end. So with this, thank you very much, and goodbye, everyone. Thank you.
Thank you very much. Appreciate it. Thank you.
Thank you to everybody.
Yeah, very good. Well done.
Thank you very much from Colombia. Thank you. Colombia.